Right. Thank you so much for being with us today. I hope that you all are having a fabulous day. Today is our next webinar in our professional development series with Partnership to End Addiction. We, as an organization at Not My Kid, really believe in sharing all of this good information around prevention and how to implement prevention in the community with other providers. This kind of training is great for schools, for any professionals who work with youth, any agencies who work with youth. And so today's webinar is on addressing co-occurring mental health and substance use problems. This is a topic that does come up a lot in our work and in our conversations and is really important. Before we get started, little history about Not My Kid. We are a nonprofit and we are in our 24th year of operation. Doing what we do prevention and behavioral health all over the state of Arizona. We believe in the power of lived experience, and our mission is to ensure that every kid thrives by inspiring positive life choices. And so one of the things that we love to do the most is partner with agencies like Partnership to End Addiction, who is a national nonprofit organization based in New York City. And today we have Corey Hammond and Dr. Richter. So Partnership's mission is to transform how our nation addresses addiction by empowering families, advancing effective care, shaping public policy, and changing culture. Dr. Richter is the Senior Vice President of Prevention Research and Analysis at Partnership to End Addiction, where she conducts research on the nature, scope, predictors, and consequences of all forms of substance use and addiction, especially among young people. Corey Hammond joins us as the Director of Prevention Services. Partnership's prevention team leverages research to help raise awareness among parents, educators, health professionals, policymakers, and best practices in substance use prevention and addiction care. So that is Partnership's introduction. I have had that bio for you guys so many times now, and I always like to make sure that we get it right because you guys are doing such amazing work nationwide with Partnership to End Addiction. So I will pass it off to Corey now, who I believe is going to kick off the education part of the webinar.
Thank you so much, Sarah. Hi, everyone. Thank you so much for joining us once again. We're so excited to bring our next installment of this professional development series. Exactly as Sarah said, this is a really important topic, and it's certainly gaining more traction in the last couple of years. And so we're looking forward to chatting a little bit about it. We have a lot that we're going to cover in this short hour, but definitely if you have questions that come up as we get started, please feel free to use the chat, and we'll try to monitor that as much as possible. And hopefully we'll have some time for questions at the end. You have already heard enough about us, but this is our team, the prevention team at Partnership. I'm the Director of Prevention Services. Linda is the Senior VP of Prevention Research and Analysis, and we have Olivia, who is our research assistant on our team. Here is what we're planning to go over today. It's going to move pretty fast because we have a lot to go through in just an hour, but we're going to go through substance use and mental health, and then what's called the co-occurrence of those two together. So having both a substance use and a mental health disorder. We're going to talk about the prevalence of this idea of co-occurring disorders. We're going to talk about the risk and protective factors. We're going to talk about the current treatment landscape for getting treatment for a co-occurring disorder and some of the barriers that exist to treatment. And then we're going to move into what parents, teachers, and health professionals can do to try to help, both in the prevention space, but also trying to get treatment once this already exists. So moving into youth substance use, mental health, and the co-occurring disorders. So substance use in general, talking to a group of professionals that work in this, I'm sure none of this is new information, so I'm going to go through it kind of quickly, but we know that the actual clinical definition of a substance use disorder is impairment caused by the recurrent use of substances despite harmful consequences and lasting changes to the brain. It's characterized by many different things. These are the kind of 11 symptoms that a professional will screen for when they're trying to decipher whether someone has a substance use disorder or not. So things like using more for a longer period of time, having difficulty cutting back, cravings, not being able to handle their responsibilities at home or at work or at school, giving up on things that were interested to them previously, putting themselves in physically dangerous situations, worsening physical and mental health problems, and then tolerance and withdrawal. And we know that a couple of these symptoms would make up a mild substance use disorder, 4 to 5 would be moderate, and 6+ is severe. And so this is important to bring up just because when we're talking about co-occurring disorders, we're not talking about experimenting with use or what you would call like recreational substance use. We are talking about the actual clinical definition of a substance use disorder. When it comes to teens, you might have seen this slide from us before, but we know that as of 2022, almost 9% of teens met diagnostic criteria for a substance use disorder. And unfortunately, less than half of those who needed treatment received it. So there was a big gap in treatment there. I'm sure you've seen this slide from us before too, but we do love to talk about this idea that using earlier increases the risk for a substance use disorder later in life. This graph on the left is the likelihood of alcohol use disorder as a function of age at first use of alcohol. We know that individuals who first try alcohol at age 12 or younger, about 12% of those went on to develop an alcohol use disorder. The odds for this group developing alcohol use disorder are 5 times higher than those who wait until 21 to try alcohol. And you'll see in the graph on the right that the story is pretty much the same with marijuana. Individuals who begin using marijuana at an early age, 12 or younger, have much higher odds of developing marijuana use disorder than those who wait until their later teens or early 20s to use. So this is why we're trying to delay onset of use as long as possible. And we'll talk about it more, but we know that using substances earlier also increases the risk of mental health problems later in life. And so this bidirectional relationship, by delaying onset of use of substances for as long as possible, we can definitely decrease the risk that someone will develop a substance use disorder, but we're also going to decrease the risk that they'll develop a resulting mental health problem. So jumping into the mental health section, here I was going to show a video, but I couldn't get the sound to share. That was basically young people describing the types of mental health problems that they struggle with. So talking about their anxious thoughts, talking about their intrusive thoughts, talking about their depressive episodes. And, you know, I think as adults, we're so used to the characterization of mental health problems through the adult lens that it can be difficult sometimes to remember that the majority of mental health problems start early teens or early 20s. And so we can't be blind to the fact that the mental health disorders are prevalent and noticeable in younger people as well. And oftentimes they look very similar. There's some stark differences, but for a lot of the times, a lot of the symptoms that we're looking for are very similar, regardless of whether someone is 14 or 30. And so when it comes to the youth mental health challenges that we see, this is some data from 2022. We saw that 64% of teens feel that the world is more stressful now than when their parents were their age. About 1 in 6 report experiencing specific negative emotions all the time or often, and 1 in 4 have been diagnosed with any mental health condition. Again, this is mirrored by this data here, and this is broken out into The darker blue bars is anxiety, the lighter blue on the right is depression. And so you'll see about 20% of all teens, this is 12 to 17-year-olds, have been reporting symptoms of anxiety in the past 2 weeks. About 17.5% reported symptoms of depression. And we'll see in the kind of later bars that this is much more pronounced in females compared to males. And even more than that, it's much more common among those who identify as LGBTQ+ than their non-LGBT peers. And so if we can, 20% for all adolescents is high, but when we break that out and look at the differences between males and females and those who are LGBT+, we can see that there are stark differences when it comes to some of these demographic characteristics, which are important to keep in mind. Emphasizing part of what I said earlier, there's good research that shows that about half of mental health problems will surface by age 14, and 3/4 will surface by age 24. And so this is important for us to know when we are thinking about whether to screen for mental health problems in younger people, and what we should be on the lookout for. This is CDC data about mental health challenges among youth. An alarming number of adolescents report serious mental health problems and suicidality, which unfortunately seems to be increasing every year. You'll see that this is the Youth Risk Behavior Survey. So this is high school data. About 10% reported having ever attempted suicide. Over 20% seriously considered attempting suicide. Almost 30% experienced poor mental health in the past month. And over 40% report having experienced persistent feelings of sadness or hopelessness in the past 30 days. And so these numbers are certainly worrying. So we don't want to be kind of blind to how serious the youth mental health challenges are today. But we also don't want to be so doom and gloom. We know that there's a lot that we can do to try to turn this trend in the other direction. And there's a lot that we can do to help, which is what we're going to eventually get to. But a little bit more about suicidality. I think we'd be doing a disservice if we didn't touch on this specifically when sharing about mental health in young people. In all ages, in 2021, suicide was the 11th leading cause of death. More than 20% of teens have seriously considered suicide. In the decade from 2011 to 2021, about 13% of high school girls had attempted suicide, 30% had seriously considered it, and that rate is more than 20% for LGBTQ+ teens, and 45% of that group had seriously considered attempting suicide. So it's important to be aware of this and knowing what students are at higher risk. And, this is not a training on suicidality and how to prevent a suicidal crisis or what to do in a suicidal crisis, but, it never hurts to be reminded of the basics that anyone, not necessarily a mental health practitioner, can do to help in a moment like that. We always talk about asking questions very explicitly, asking, are you thinking about killing yourself? We know that the research shows that asking that question as explicitly as possible is the best way to learn what is going on and intervene. Reducing access to lethal means is so important. Just being there, listening, and acknowledging feelings, helping them connect to 988, which is the new national suicide hotline, which is a really valuable resource, and then following up and staying in touch after a crisis. If anyone has gone through mental health first aid training, this kind of mirrors what they teach you in that training. So moving into, we've touched briefly on the substance use component and the mental health component, but talking about specifically what this looks like when those come together. So we call that co-occurring substance use and mental health disorders, often shortened to COD, co-occurring disorders. And so again, this is the presence of both one or more mental health disorders and a substance use disorder. And so again, it's the clinical definitions. So the conditions need to be met for the diagnostic criteria, which is laid out in the DSM. And we know that COD, co-occurring disorders, affects people across all demographic groups. We know that this is not an inherently American problem. We know that this exists all over the world with all people. And this is important to call out and talk about specifically because compared to people who have just a mental health disorder or just a substance use disorder, people with a co-occurring disorder have much more profound functional impairment. They have much worse treatment outcomes. They have much higher morbidity and mortality rates. Their treatment costs are higher. There's higher risk for homelessness and incarceration, and they're at much higher risk for suicide. So basically everything that we're worried about when it comes to substance use or mental health disorders is so much more serious and exaggerated in people who have this co-occurrence. And unfortunately, this is not a rare thing. In 2022, about 22 million adults in the US had a co-occurring disorder, including 5.3 million young adults, so about 15% of those aged 18 to 25. When it comes to teens specifically, 12 to 17, about 1 million adolescents had a co-occurring major depressive episode and a substance use disorder in 2022. So if we factor in all mental health disorders, that number would be higher, but this one study just looked specifically at depression. And, you know, of those adults or of those adolescents, about 20% had a major depressive episode, about 15% had severe impairment due to this. We know that the rates are higher among females than males. And unfortunately, as we're going to talk about, treatment is difficult for co-occurring disorders. Only about 20% of those adolescents receive treatment for both their substance use disorder and their major depression. 50% of those who got treatment received treatment for their mental health disorder, but not for their substance use. But then the flip side of that, only 2% who 2% who received treatment for their substance use disorder, but not for their major depressive episode. So if someone's going to get treatment and has a co-occurring disorder, it's much more likely that their depression or their mental health problem is going to be what's treated. It's unlikely that someone's getting treatment only for their substance use disorder and they're not getting treatment for their mental health. But again, only about 20% received treatment for both, which we know is really important. And then just emphasizing this idea of a bi-directional relationship, that once someone has both a mental health disorder and a substance use disorder, they feed off of each other and they impact one another. And we know that these go together for a reason. If a person is struggling with negative emotions or wanting to ease the symptoms of their mental health disorder, they might self-medicate with substances, especially if their mental health disorder is not very well treated. You know, so if a child has that mental health disorder and self-medicates, they can very quickly start to rely on that substance to alleviate their symptoms, and that could lead to them developing an addiction or a substance use disorder. But then vice versa. We know that using substances like alcohol or high potency marijuana can trigger or exacerbate a pre-existing mental health condition. So we know that if a child is struggling with a mental health disorder, they're at higher risk to use and then misuse substances. But on the other hand, if your child is already using substances, they're more likely to develop a mental health disorder. So it's kind of a seesaw. These go back and forth and are highly dependent on one another. And so these are some of the mental health disorders that commonly co-occur with a substance use disorder. I'll go through them in more detail, the ones that are most common among teens and adolescents. So the ones like major depression, anxiety disorders, ADHD, PTSD, bipolar, schizophrenia, but also things like eating disorders, which I think don't get talked about nearly as much, though the relationship to substance use disorders certainly is very prevalent. I'm not going to go into depth about eating disorders, but we do know that about a quarter of individuals with anorexia and almost 40% of those with bulimia are diagnosed with a substance use disorder. And so we know that these go hand in hand very frequently. And also kind of a symptom of many of these mental health disorders, but also just in general, self-harm also very commonly occurs with substance use disorders. And so a brief bit about depression, both major depression and persistent depressive disorder. I'm sure everyone has heard of this and kind of knows the hallmarks of what major depression looks like, but we know that it involves persistent shifts in mood, eating, sleep habits, or interests. Something to call out here is that depression can look slightly different in teens than in adults. You know, often with adults, you'll see the commercials of someone being very gloomy and down in the dumps and sad. Depression in teens can sometimes come across more as irritability or mood swings and anger. And they're more likely to report a loss of interest in things that they once enjoyed than they are to report just kind of that general sadness feeling. Teens with depression are 2 times as likely to use substances than their non-depressed peers. You'll see this graph here, the purple bars are teens who have had a major depressive episode, and the yellow bars are those who have not had a major depressive episode. And so you see that with all substances, the purple bar is significantly higher than the yellow bar. Teens who have had a major depressive episode are much more likely to use substances than their non-depressed teen or counterpart teens. When it comes to rates of substance use disorders, teens with depression have 3 times higher rates of substance use disorders than teens who don't have depression. And so a little bit more about that. It may come as no surprise that youth may use substances to dull painful feelings that they have or cope with persistent negative thoughts. It's very common, not just among teens, but in total, nearly a third of people with major depression also have a substance use disorder. And it's interesting that, substances affect the reward centers of the brain, and that's the same areas that are also associated with depression. And so we know that for someone who uses substances and has depression, if they stop using substances, they can then feel even more depressed when they're not using those substances than someone who is not depressed. We talk about alcohol specifically as being damaging for someone who has depression, especially for teens, because it affects teens differently than it does adults. We know that in the adolescent brain, alcohol causes teens to get more energetic and behave more risky. Adults often get sedation effects, not so much the case with teens. And so when teens are engaging in more risky behavior, especially those who have depression, the risk of self-harm increases. A quick bit about anxiety. The definition of anxiety is when anxious feelings escalate to a point that they interfere with a young person's ability to handle everyday situations and prevent them from enjoying their usual activities. And so anxiety disorders would include things like generalized anxiety disorder, social anxiety, separation anxiety, specific phobias, and panic disorders. Again, no surprise that youth may use substances to try to alleviate anxious feelings that they have. The effects of substances can cover up or mask that anxiety, so it may be more difficult to assess the disorder for someone who's trying to screen a young person for anxiety. Again, some may feel that their anxiety is more intense when they're not using substances. There was a large survey of, I think this is just adults, of almost 20% of respondents with a substance use disorder also had the diagnostic criteria for an anxiety disorder. And it's also interesting that generalized anxiety disorder is associated with an accelerated progression from first use of a substance to a full-on, like a full-blown substance use disorder or an addiction. And that comes from most likely that effect that they have these anxious feelings, so they try substances, those anxious feelings go away. And so then very quickly it moves into addiction. A little bit about ADHD. Attention deficit hyperactivity disorder is diagnosed when a person has difficulty concentrating, paying attention, sitting still, following directions, and controlling impulsive behavior. I'm sure that we kind of all know the signs and symptoms of ADHD at this point: being easily distracted, appearing to not listen when spoken to, having trouble with organization, consistently fidgeting, excessive talking or interrupting, blurting out answers in school, things like that. And so because ADHD is so common, the co-occurrence of ADHD and substance use can be concerning for parents. The structural and chemical brain differences associated with ADHD make young people more responsive to the effects of substances and more likely to engage in substance use. And so I'm sure a lot of parents of ADHD children are worried about this. But there is good research that shows that if a person is treated for their ADHD successfully before age 12, then they're no more likely to develop a substance use disorder than any other person. But we do know that nearly 25% of young people with a substance use disorder also have ADHD. We know that people with ADHD are drawn to stimulants. So about 15 to 25% of people who use cocaine have ADHD. About 40% of adolescents who engage in problem cannabis use have an ADHD diagnosis. And because young people with ADHD can be prescribed stimulant medication, they may misuse medications. And so certainly some parents are concerned that taking stimulant medications will lead to substance use. But again, there's good research that shows that if prescribed appropriately for someone with a legitimate diagnosis, those medicines can help subvert substance use, as the child will be less driven to self-medicate. But likewise, without appropriate prescribing of stimulant medication for kids who really need it, the risk for their substance use increases because they will self-medicate often. PTSD, I'm sure we all know the definition of PTSD, but it occurs in people who have experienced or witnessed a traumatic event. Could be natural disasters, serious accidents, combat, sexual assault, trauma, domestic violence. Symptoms include intrusive thoughts, avoidance, changes in cognition. For the clinical definition, symptoms need to last for more than a month and cause significant distress or problems in functioning. It affects about 3.5% of adults every year. Lifetime prevalence for adolescents. So about 8% of adolescents will go on to have PTSD at some point in their life. Females are twice as likely as males to have PTSD. When it comes to PTSD and substance use, about 62% of children and adolescents in the US have been exposed to a traumatic event. About 16% of those will go on to develop PTSD. Adults with PTSD are 2 to 4 times more likely to have a co-occurring substance use disorder. And lifetime prevalence of PTSD in treatment-seeking people with substance use is 50% or higher. In most cases, the PTSD comes first. So someone experiences a traumatic event and then is having PTSD from that traumatic event, and then engages in self-medication or problematic substance use to deal with that then turns into a substance use disorder. There is good evidence of successful treatment outcomes with medication to treat both PTSD and substance use disorder. So things like combining naltrexone with an antipsychotic or an antidepressant can be really successful in people who are struggling with both of these. Bipolar, teens and young people with bipolar disorder show signs of depression and mania, so periods of excitability or irritability, exaggerated self-confidence and recklessness. And we know that bipolar and substance use are inextricably linked. Nearly 60% of people with bipolar also have a co-occurring substance use disorder. We know that substance use can trigger a first manic episode in people who have bipolar disorder but don't yet know about it. And unfortunately, many of the substances that people with bipolar are drawn to, so things like nicotine, alcohol, they can interfere with their antipsychotic medications. So it's really important for, if someone is getting treatment for their bipolar disorder, it's really important for them to be forthcoming about their substance use so that they can be prescribed medication accurately and knowing about the substance use, because there is some interference there at times. Going into the risk and protective factors. So what can we learn about co-occurring disorders to try to prevent it from happening? I've already kind of discussed all of these, but these are the three pathways to developing co-occurring disorders. So the first pathway is someone who has an existing or emerging mental health challenge and is turning to substances to self-medicate. The second is someone has a predisposition to both. They're predisposed to mental health disorders. They're also predisposed to substance use disorders, whether based on their genetics, whether based on the risk factors that they have in their external life, just whatever's going on, they're predisposed to both. And then the third is that someone starts using substances first, and then because of that has a change in their mental health status. And this one I think is slightly less common, but we do hear stories about this of someone who is prescribed medication, maybe after a sports injury or a dental procedure, and they don't yet have any sort of underlying mental health disorder, but the onset of that substance use, whether it's using more of that medication than necessary, then kind of starts that pathway and then eventually causes a change in the mental health that leads to the mental health disorder. So the substance use comes first and then the mental health disorder. And so these are some of the risk factors for a co-occurring disorder. Some of them are pretty logical and obvious. They're risk factors for substance use, but also mental health at the same time. So we know that a risk factor, some of it is just biology. There's some differences in brain structure or how one's brain functions that puts them at a higher risk for substance use or mental health problems. We know that family history plays a part in both of these things. Stressful events, abuse or trauma, bullying, a strained parent-child relationship, significant life disruptions, feeling disconnected from school and friends, feeling unsafe at home or school, having a chronic illness or chronic pain. And then we know that using substances, misusing prescribed medications can put someone at higher risk for both a substance use disorder and a mental health disorder. A quick word about social media as a risk factor. We know that social media has a direct impact on the mental health of teens who spent more than 3 hours a day on social media. heightened risk of mental health problems. We know that this effect is especially pronounced on girls' mental health. We know that some of the negative effects are due to disrupted sleep. We know that cyberbullying plays a big proponent, lack of exercise, and it's particularly risky for the development of internalizing problems, so anxiety and depression, rather than some of the externalizing problems like bullying or aggression. And so if we know that someone in our life is at a predisposition to substance use or mental health problems, especially internalizing problems, we may want to think about how much they're using social media, what type of screen time they're getting, and what they're looking at and how that could impact their risk. But we know that there's a lot of protective factors that exist. Having loving, nurturing parent or guardian support, feeling safe at home in their community, feeling connected to their school and their friends, working towards a healthy lifestyle, having that be something that's important to them, engaging in substance-free social activities, having strong problem solving and coping skills, having this feeling of resilience, being spiritual is a protective factor. And we know really important is the bond with at least one trusted adult, whether that's a parent, a sibling, a teacher, or a coach. All of these are things that, regardless of risk factors in someone's life, these are things that can keep someone protected. And so a little bit about the treatment landscape, because we know as much as we want to prevent co-occurring disorders, we're never going to be able to prevent all of them. Some people will still, no matter what we do, have co-occurring mental health and substance use disorders. And so how do we get them the help that they need? The treatment landscape, I'm sure all of us are aware, the treatment landscape in the US is complicated. And when we think of substance use and mental health treatment, especially substance use treatment, a lot of times people are thinking of detox or a rehab facility, and maybe not much else. But there are a lot of different levels of care that we can think about. And so you'll see this, it starts on the left with outpatient care, which is the lowest intensity. And then we move up in intensity, moving into intensive outpatient treatment, where someone's still living at home, but they're spending 10 or 20 hours a week at a treatment center getting care. Partial hospitalization, still living at home, but we call that high intensity. And then further down the line, we have residential treatment, where someone is living on site for a month or more. And then finally, inpatient, where someone's living at a hospital or a medical facility for days to weeks. And we know that the level of care that someone needs depends on a whole host of factors: what they're using, how serious their mental health problems are, how long they've been using, whether or not they've tried other forms of treatment in the past. There's a lot of factors to take into consideration. And we know that if someone's dealing with a mild mental health problem and a mild substance use disorder, we're not going to immediately stick them into inpatient medical facility as the very first line. But taking a step back, we know that there's what's called the window of opportunity. And this is something that we really try to teach parents about. We want parents to be aware of changes in their child's mood or behavior, to identify when they might be at risk of developing a mental health disorder or a substance use disorder. There's a really key, what we call window of opportunity, between the onset of a mental health disorder and then the subsequent substance use disorder, because that's how it goes with most people. About 90% of those who end up with a co-occurring disorder had at least one mental health disorder prior to the onset of their substance use addiction. So generally, the mental health disorder occurs in early adolescence. The median age for that's about 11, and then followed by the substance use disorder 5 to 10 years later. And we know that once someone has developed the substance use disorder, treating both in tandem becomes considerably more complex and difficult. So if we can intervene at the time where the symptoms of the mental health disorder are starting, we can do our best to try to prevent that subsequent substance use disorder 5 to 10 years later. So we really try to teach parents about this window of opportunity that, you don't want to just think that it's just a phase, they'll grow out of it. Middle school is hard for everybody. I'm just going to let it go and play it out and see how things shake out. We really want to get help for kids when they need it so that we can prevent that pathway from coming to fruition. Even if we recognize that something is different in a child and we refer them to care and we are doing our best, there are barriers to treatment. And we would be doing a disservice to ignore these things because not everybody who wants to get treatment is able to do that. Some of the barriers to treatment are availability of qualified staff, the willingness of the adolescent to get into treatment. There is considerable stigma around medication for mental health and substance use disorders. There's lack of insurance or difficulties getting coverage. Logistics are difficult, especially if you're trying to get treatment for a young person who's still in school. So trying to work around school hours, getting teens to and from. There's often wait lists. There's been a decline in residential treatment options available for adolescents. And many adolescent programs don't offer evidence-based care, which we know should include family involvement if possible. And so if you're able to put something in the chat and would like to start a conversation, I'd love that. But if not, just kind of think to yourself. If we could take a moment and just think about what barriers to integrated treatment might exist specifically in your community, if we're thinking about Arizona, you can put something in the chat if you like, or just, think to yourself. If we're aware of what barriers exist in our community, we can try to break them down and get treatment that we need for people. I see someone put no insurance as the first one. Yeah, that's a high cost from Danielle, definitely. And unfortunately, these are large systemic problems that need large systemic solutions. Yeah, thanks for sharing. If anyone has more, definitely feel free to put them in the chat. But otherwise, I'm going to keep moving into specific barriers that we've heard of. This is what research shows from parents and caregivers. A parent may have the best interests in the world for their child and is trying to get help, but may not be able to. Turnover in staff, Jessica, yes, absolutely. This comes from a research study that showed about 60% of parents had difficulties finding a trusted mental health provider for their teen. Again, almost 60% felt that financial concerns or perceived stigma are also important barriers. Almost 90% of parents reported having medical coverage, but less than half reported behavioral health coverage. So parents may turn to their pediatrician, who may or may not be trained in addiction care and may or may not know how to refer to outside care. And the Mental Health Parity and Addiction Equity Act, so that federal parity law, was passed in 2008, and it does require health insurance plans to cover behavioral health benefits and physical health benefits equally. So this idea that if you have medical coverage, it should pay for behavioral health coverage. Unfortunately, this law is not well enforced, and getting that equal parity coverage is difficult. So there's ways to appeal if a claim is rejected, but not everybody knows how to do that. Partnership does have some resources that we can share. We'll share at the end of this presentation for people who are looking for help trying to get behavioral health coverage for themselves or their children. And then there's other studies that have talked to adolescents. So like for young people who are not receiving mental health treatment, even though they sought it out at some point or thought about getting it, a lot of it came down to stigma. Young people were worried that they were worried about what people would think or say about their getting mental health or substance use treatment. They were worried that their information wouldn't be kept private. They thought that their family, friends, or religious groups would disapprove, or they just thought that they'd be able to handle it on their own, and that after all, they maybe didn't need help. Access, they didn't know where to get it. They had cost concerns, difficulty getting to appointments and treatment barriers or transportation barriers, and then low confidence in treatment. Either they thought that they're not ready for treatment, their problems maybe aren't bad enough for treatment, or they just didn't think that treatment would help. And so these are things to consider if we're working with adolescents that we think might need treatment, being aware of the barriers that exist kind of internally and externally for them getting treatment. And now I'm going to pass it to Linda to go into some of the good news, what we can do about this rather than just kind of how dire the state of things is.
Thank you, Corey. Thank you for also taking the bulk of this. Sorry about my voice. I have a little bit of a cold, and also sorry, Corey, for giving you all the dire news when I come in, swoop in with the good stuff. But there are important ways to help. And as Corey mentioned earlier, there really has been a sea change in the past couple of years about the importance of recognizing co-occurring disorders, especially among young people, and addressing it in a different way than it has been addressed in the past, which I'll talk about in a second. You can go to the next slide, please. So before we talk about what you all could do in your professional roles, it's really important to understand what we could encourage parents and caregivers that we work with to do. Again, as always, it sounds very, basic, but to encourage them to have frequent and honest conversations with their children. The only way to really know what's going on in kids' lives is if there's this routine openness between parent and child or caregiver and child, so that caregiver could recognize if something is shifting, if something is changing in mood and in appearance, and any of the indicators of a substance use or mental health problem, or both. If a child is in treatment for either substance use disorder or mental health disorder or both, it's really important to have clear expectations of the boundaries and the treatment goals. One element that's really helpful for young people especially is to ensure that they're not just in this sort of treatment mode, but also engaging in activities that are healthy and positive, that don't involve substances. So you need both parts of it. You need the treatment element, but also part of that treatment element is encouraging positive activities and engagement among young people. As I said before, being really aware of any changes in behavior or mood or appearance in young people. Those are not signs to be dismissed. Those are signs to be paid attention to and addressed. We really talk a lot about parental or caregiver modeling for young people, and the importance of modeling not just good coping skills and low substance use or safe substance use for adults and all that, but really the importance of getting help when needed. A lot of kids get the message inadvertently or directly from the adults that they look up to in their lives that if you're strong and you're brave and you're a solid person, you won't need outside help, and you should just kind of manage your issues on your own. And that's a really dangerous message to deliver to young people who may be struggling with some serious issues. So the more we can model for young people that it's okay to ask for help and get help when needed, and that it's not just okay, but it's a really positive and strong thing to do, then we're going to set our kids up for better outcomes if they are struggling. And then if it's at the point for parents where they actually know that their child is struggling with substance use issues in particular, we do really want to try to encourage harm reduction techniques in the home, like keeping Narcan or naloxone available and ensuring that the child is safe if they are using substances. And as Corey mentioned earlier, it's really, really critical that whenever they see any kind of health practitioner, a pediatrician, a dentist, a therapist, a psychiatrist, whoever it is, where medications might be prescribed, or even if not, that the health professional is fully aware of the child's co-occurring disorder diagnosis. Because again, as Corey mentioned, I think earlier, prescribing certain medications for a young person who has a mental health issue or a substance use issue could really prove dangerous if it's not done with full knowledge of their condition. Differential diagnosis is a clinical term, but it's important here because it kind of is trying to show what the overlap is between substance use and mental health disorders, and when it's a co-occurring disorder versus just one or the other. So we kind of can get at whether it's a co-occurring disorder if, for example, the depression or sadness is related, you know, whether if it's related to something that actually happened recently in a person's life, then that's depression or sadness. But if it sort of seems to come from nowhere, then it may involve a substance use, prompt, or a substance use may be, bringing on the depression, and there might be a co-occurring disorder there. Another example is if a young person is using substances to cope with mental health challenges, that's a clear indication that there may be co-occurring disorders in that person. Again, if the substance use is a response to a stressful life event, to a mental health problem, to something going on, then again, a co-occurring situation might be there because they're not just using substances for fun or to experiment, but they're using it because of negative feelings or emotions. So these are just some examples where whenever you're seeing there's a strong link between the substance use and a mental health challenge, or that a mental health challenge is arising due to a substance use problem, that's where co-occurring disorders should be screened for and treated if necessary. And if you are referring a young person to treatment, what we've learned over the years recently is that what's really critical is to ensure that the treatment facility or provider provides integrated care, meaning they are not treating the substance use and the mental health disorders as two completely separate, unrelated issues, but rather as very deeply intricately woven together conditions that have to be addressed simultaneously. We do know for young people, whether it's for substance use, mental health, or co-occurring disorders, that involving the family is key whenever it is possible. Outcomes are much better for young people when there is parental or caregiver involvement in the family, in the treatment, because a lot of the issues that arise for young people when they have a substance use or mental health disorder or a co-occurring disorder does involve the family. And if you only treat the individual young person without the family, then you are missing usually a large chunk of the picture. We do want young people to be referred to programs that promote mentorship, as Corey mentioned, and a responsible adult who's a caring adult, a trusted adult for a young person is one of the key protectors for them. So mentorship programs or programs that encourage mentors is really critical. Having a recovery community, and really continuing care and relapse prevention is really critical for young people as well. We don't want to just have a young person go to some sort of treatment for a specific amount of time, discharge them, and then that's the end of it. Everybody needs continuing care, but it's especially important for young people. We do want to point out that there are a whole range of emotional support, mental health, treatment platforms online. Some are better than others, but these should all be kind of, used cautiously, because unlike a formal mental health treatment program where they are credentialed and they're licensed and they're, there's all sorts of regulations around them, there's really very little recourse now for someone who has been harmed by one of these emotional support platforms that you can access on social media or online. It's fairly unregulated. And there's federal laws that protect these sort of social media and online platforms from damage that may occur to an individual who uses them. So to the extent possible, what we want to do when we're helping families or young people is to encourage them to use formal programs instead of one of these online platforms. This is an interesting slide from the study that Corey mentioned earlier about, young people's perceptions of mental health. And it's that we often think that kids don't want to hear about these things in schools or in their kind of community organizations. But in fact, this research shows that the majority of kids actually do want schools to play a role in their mental health, and they actually trust the information that they get from their schools. So we do want to encourage the schools that we work with to take this issue on and take it seriously for young people. One thing that's really important to talk about is that traditionally treatment, as I've mentioned earlier, has been separated as opposed to integrated for mental health and substance use. And that's really a significant problem because substance use disorder treatment tends to not really pay much attention to mental health disorders. It typically requires abstinence from all substances, including those that might be prescribed to treat a mental health problem. They often have little individual therapy time, which is not helpful for someone with a mental health problem. Some programs still involve blaming and shaming, which again, very detrimental to someone with a mental health issue. And they may discharge a patient with a substance use disorder if they're demonstrating mental health challenges. So there's often this kind of revolving door situation where people come into treatment and then get discharged prematurely and go in and go out, and it's not effective if the mental health disorder is not well treated. Vice versa, when you look at mental health disorder treatment programs that don't take into account substance use, they may simply not admit patients who have a history of substance use, and they may discharge patients if they note that substances are being used, and discontinue mental health medications, if they think a patient might be misusing substances. Again, this approach is really unhelpful to people who have a co-occurring disorder. That's why we really encourage, and there's not many of these programs, but they're increasingly common, which are integrated treatment programs that, again, emphasize the importance of intervening early, coordinating the treatment for the substance use and mental health issues simultaneously, encouraging positive and supportive social engagement and interactions and healthy activities involving the family. And where it says no wrong door, that means if someone comes in concerned about their mental health, they're always checking also for a substance use issue. If someone comes in because of a substance use problem, there's always this screening and check for a mental health issue, understanding that those two problems co-occur quite commonly in young people. I won't go into detail on these, but these are just some of the effective modalities for clinical interventions for people with co-occurring disorders, and they'll look familiar to those of you who know something about mental health treatment and substance use treatment. They're not that different, but they do involve, and there are also specific interventions for the families of young people who may have a co-occurring disorder that are really helpful to supporting not just the parents or caregivers, but the child or young person, him or herself. And then again, always for the young person, having these kind of pro-social positive activities is really an essential component of effective co-occurring disorder treatment, as is building coping skills, etc. So just real quick, I know we're out of time. I just do want to run through a couple of the resources. Partnership to End Addiction ourselves. These are free resources that we have. We have a guide that was published in conjunction with the Child Mind Institute in New York on co-occurring disorders, and we have a webpage with lots of articles and information on this topic. This is something related to what Corey was mentioning earlier, which some of you indicated, that cost and insurance is a real barrier to getting care for co-occurring disorders. We've done a lot of work on the policy side, trying to identify ways to help families navigate the system when they've been rejected from insurance, etc., to pay for co-occurring disorder treatment or any treatment, actually. So these are really useful resources that you could share with the people that you work with and the families that you work with on how to kind of get resolution if treatment has been rejected due to costs or insurance problems. We work with this terrific organization called the Harris Project that has really nice resources for parents and for professionals on addressing co-occurring disorders in young people. And the federal government has some really great resources that you may be familiar with, specifically SAMHSA, the Substance Abuse and Mental Health Services Administration, on how to identify, screen for, and treat co-occurring disorders that are worth looking at if this is a population that you work with. So since we're over time a little, this is our contact information. If there are any questions or any more information you'd like, we really have been doing a lot of work in this area. We'd love to share more with you if you're interested, and I'll pass it back to you, Sarah.
Thank you. I do want to give just a second. I know that we're over time. I just want to give just a second. If anybody has any questions, feel free to put it in the chat now, or you are always welcome to contact Corey and Dr. Richter, or you can contact Not My Kid. A email for Not My Kid, I'll put in the chat right now, is info@notmykid.org. And then also feel free to visit our website, notmykid.org, for more information, more resources. We have a lot of great programs and services for teens and families. And then for other webinars, if you are interested, you can check out our YouTube channel. Our handle is Not My Kid Vids on YouTube. So you can also check that out. I don't see any questions coming through, so we can wrap it up. Thank you everybody so much for being here with us today, and we will see you next month for the next webinar in the series.